3rd September. So I'm going to present a selected case. Mr. X, 55 years old, non-diabetic, hypertensive male, presented with central compressive chest pain for 10 hours. On examination, pulse was 65 beats per minute, blood pressure was 110 over 70 millimeter of mercury, and precordium examination revealed normal findings. Lung bases were clear. ECG was done immediately, which showed acute myocardial infarction inferior. Tropi was elevated 1.33 nanogram per ml, and other parameters, biochemical parameters, were within normal limits. Echo revealed inferior wall hypokinesia and a fair left ventricular systolic function. Ejection fraction was 55%. So the patient was diagnosed as a case of AMI inferior with hypertension. In CCU, we gave immediate treatment with loading doses of aspirin and clopidogrel, atorvastatin, and thrombolysis was done with injection streptokinase. And we planned for coronary angiogram. Coronary angiogram was performed on 28 August 2021. This is areocranial and epicranial view showing type 3 LAD, and LCF is non-dominant. Otherwise, normal findings. And this view shows showing there is 95% stenosis at mid RCA, and there is 40 to 50% stenosis at distal RCA. Angiogram report, which shows left main is normal, LAD type 3 vessel normal, LCX non-dominant, normal vessel, OM2 has minor plaque, and RCA is dominant, 95% stenosis at mid RCA and 40 to 50% lesion at distal part. So our diagnosis is single vessel disease. So the plan was to PCI to RCA. At first, at Judkins right 6 French guide catheter was in RCA. A 2.5 by 12 millimeter PTCA balloon is placed at the lesion and inflated at 10 atm. After preparation of vascular bed, a 2.75 by 40 millimeter drug-eluted stent was advanced in the RCA, but stent did not enter inside the RCA. Several attempts were made to negotiate the stent, but the stent got stuck and not moving inside the guide catheter, and it was apparently dislodged partially inside the RCA. So a 2 by 10 millimeter PTCA balloon is negotiated in the proximal part of the stent and inflated at 5 atmospheric pressure, and the full assembly, stent, guide wire, and guide catheter was removed from RCA. Inside the descending thoracic aorta, the proximal part of the stent was seen inflated and was failed to negotiate inside the guide catheter. So what should be the next step? Sir, should I proceed, or I will discuss further what was done?
I think you can show. Proceed on.
Okay. So a second vascular access was obtained through the LFA, left femoral artery, and the course of the artery was found to be tortuous and a pterymo guide wire was negotiated through the left femoral artery into the aorta. A Hyperion snare is introduced through the left femoral artery. After several attempts, distal end of the stent was caught. Then the PTCA wire was removed and stent was pulled back. Finally, the stent was removed through the left femoral artery. Here, this is the picture showing the removed stent with the Hyperion snare. And then the right coronary artery was catheterized again and PTCA was done. A 2.75 into 33 millimeter regulatory stent was inflated at 11 atmospheric pressure and a TIMI-3 flow as established in the right coronary artery. And this is the final result. The hardware used, the root was right and left femoral artery. Guide catheter was Jupin's right, 3 by 6 French. PTCA wire was run through 0.014 inch and pterymo 0.014 inch. PTCA balloon was thought 2.0 into 12 millimeter and U4 2 into 10 millimeter. Stent to RCA was giant spine LL drug-eluted stent 2.75 into 33 millimeter. And a Hyperion snare was used to retrieve the dislodged stent. So the final take-home message is embolization of the equipment into the coronary tree is dominated by dislodgement of the stents. The most important consideration in avoiding complications associated with stent embolization is to select appropriate tools and strategies. Use of routine tree dilatation of a target lesion, careful guide alignment with the ostium of the target vessel, and appropriately supportive wires may minimize incidences of stent loss. The most consistent device, easiest to use and readily available are the coronary loop snares, but some other devices may have an important role. So thank you for your very patient hearing. Thank you all.
Thank you, Dr. Mostafa. Okay, you have removed your screen share. And thank you for presenting a complication of PCI. Practically, it's a very challenging job. Job is done well, and for learning purpose, we shall have to discuss why it has happened and how we shall have to avoid and what else could be done. This is for learning purpose, not for criticizing someone who has done it, but the outcome of the job is excellent. He has nicely retrieved, so result is good. And now the floor is open for discussion. Particularly, this is a high-tech subject. I think students may participate if they want to participate. Otherwise, our faculties can talk. Thank you. Anyone can start, either our students or our colleagues.
May I have comments, sir?
Yes.
Thank you for presenting an excellent case. I must thank the presenter. He presented very nicely, as well as the operator who did the case and rescued very uneventfully. So we must. There is a talk that in intervention we must respect our complications, and we learn from our complications. And we must respect our complications. However, there are some points that already mentioned that why the fast stent there is difficulty in negotiating fast stent